Hello, everyone. Welcome to Community Chats. This is Sandra Arevalo. I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital. And today we couldn't finish the month without talking about breast cancer. And the reason why I'm saying that is because October is the month dedicated to breast cancer awareness. And of course, we had to be talking about that and creating some awareness in our community around this topic. Now, who is better to talk about breast cancer than our own Dr. Sonny Mitchell? She's the director of the breast cancer here in Montefiore Nyack, which I love. I have to say, I always go there for everything. I love the robes. They're nice and cozy. I always want to take one home. They always tell me no. Maybe one day they'll say yes. So I'll keep asking. But anyway, that's a sidebar. Thank you so much for being with us today, Dr. Mitchell. I know you're always busy, but you always manage to come and get closer to the community and answer all of our questions. So I appreciate you for that.
Thank you, Sandra. It's my pleasure to be here as always. And thank you for everything that you do for our community. It never ceases to amaze me that every time I turn around, you have another event, and I appreciate it. I know the community at large appreciates it as well. So I think what you had asked that we do today is have a conversation about breast cancer and breast health and breast screening, and we open it up to any questions that anyone may have. Thank you for mentioning that it is October still. It's Breast Cancer Awareness Month. I would like to take this opportunity also to thank our foundation and Tracy and the entire hospital for a huge event they put on last weekend, the Rides and Strides, which was a great event that raised a significant amount of money for breast cancer screening for specifically women who are uninsured or underinsured. So, that's incredible. And the community really came out in full force, and it was a lovely day, by the way, as well. So breast cancer screening, how we do it is with a mammogram. A mammogram is the gold standard for detecting any abnormalities or breast cancer in a breast. And basically it is an X-ray. And for the typical person, we recommend that it be done once a year, usually starting at age 40, and then continuing every year. Sometimes we start mammograms earlier on women if they might be at higher risk for breast cancer. We may start getting a mammogram or other imaging such as an ultrasound or an MRI before age 40. So right now, though, standard of care is if you are 40 or older and a female, a mammogram on a yearly basis. Oftentimes an ultrasound may be added to that mammogram that you get every year, and the ultrasound provides some additional information. It's helpful when people have dense breasts. Dense breast is just kind of a way to think of it might be the breast tissue is like a little bit thicker kind of, and it's harder for the mammogram to get a really good look through that tissue. So in those instances, an ultrasound may be added to your regular mammogram. The other form of imaging that we use as well sometimes is an MRI that does not use radiation, and it provides additional information on the breast tissue as well. So typically a mammogram, sometimes a mammogram and ultrasound, and sometimes a mammogram, ultrasound, and MRI. Then when women are at higher risk for breast cancer, a MRI may be added to their mammogram every year besides an ultrasound. Those women who are at higher risk may have 2 breast exams a year, either here at the breast center or one at the breast center, one with their gynecologist or primary care. We, get their routine imaging, encourage compliance with that, and encourage everyone in general, to eat well, to exercise, on a regular basis. And so those are the basics. Breast cancer is, for the most part, for most people, a very, very treatable disease these days. Once in a while, there are breast cancers that require a lot of treatment and are more difficult and challenging, but the majority of breast cancers by far are incredibly treatable, are identified at an early stage, so very early on, and treatment is getting better and less and more tailored every day, it seems like. So that's a beautiful thing. Breast cancer currently is getting treated based off of the specifics of that individual's specific breast cancer and the characteristics of that breast cancer. Gone are the days when everybody has pretty much the same treatment for breast cancer. So the ability to tailor treatment, the ability to de-escalate treatment and specify everyone's treatment recommendations on an individual basis really affords women and men to go through the breast cancer diagnosis and treatment process and continue to move on with their lives. So those are the basics with that. If you notice a lump or a bump on your breast, or have discharge from your nipple, or some skin changes on your breast, or it just feels different, that's always a good reason to go in and check with your gynecologist or your primary care, of course, your breast surgeon as well, if you have one, or if you want to come to the breast center. And then that would typically lead to imaging, an ultrasound, a mammogram, or reassurance that everything is completely okay. So the people that are involved with breast cancer treatment are breast surgeons and medical oncologists, radiation oncologists, radiologists, and pathologists. Also geneticists or genetic counselors, social workers, and clinical coordinators, nutritionists. The list is very long, but the reason for that is it's very important to maintain a really healthy, strong, multidisciplinary team in order to efficiently and accurately treat breast cancer. So breast surgeons are typically the person who would operate on the individual with breast cancer. The types of breast surgery that we have available today are much better than what we used to have, and that's purely a result of a tremendous amount of research and data and advances in technology, advances in knowledge of breast cancer, most importantly. We also have medical oncologists. Is this too much information, Sandra, do you think?
No,
Okay. Okay.
I'll
Okay.
help you.
Okay. We also, the medical oncologists are hugely important. They provide medication for individuals with a diagnosis of breast cancer. It might be as simple as a pill, something like a tamoxifen or anastrozole. It might be something as simple as some immunotherapy or some chemotherapy. So medications come in different forms and are really great when they're required for a treatment of a specific breast cancer. Our radiation oncologists are incredibly important as well. Radiation is a very important component for some breast cancer treatment. A beautiful thing about radiation, like all of the aspects of breast cancer treatment, is our radiation oncologists are more frequently able to do a shorter course of radiation, a shorter time period. That's really beneficial for individuals. Each breast cancer is taken into account on an individual basis, and the radiation oncologist will figure out what the best recommendation is to treat that specific breast cancer for that individual, the medical oncologist as well, the breast surgeon as well. We really like to get a genetic counselor or geneticist involved with everyone who has a diagnosis of breast cancer if they'd like. Even individuals who may be at higher risk for breast cancer, our geneticist is always available. Genetic testing or genetic counseling, it can sound rather intimidating. In reality, all it is having a conversation, answering some questions from the geneticist. It's the same kind of questions you answer when you go to your doctor. If you have a family history of certain cancers, and then they will offer to you testing. Genetic testing usually entails either a little bit of spit, saliva, or a small amount of blood, a blood test that is sent off to a lab, and they run a bunch of tests on it and see if you may be at increased risk genetically for specific types of cancer, other breast cancer, ovarian cancer, a variety of cancer. So that information is very, very helpful. It allows people to feel empowered and to be proactive in controlling the things that we can control, such as exercise or nutrition, no smoking or alcohol, things along these lines. Also helps people feel empowered because they can get the appropriate screening that they need for, if it's increased risk for breast cancer, they'll get the breast cancer screening that they need. If it's another type of a cancer that has its own specific requirements, then they will be able to get plugged into screening for that as well, which is really, really great. It also helps people feel a sense of relief if they are gene negative. Most breast cancers, interestingly, are not associated with a positive known gene. So most breast cancer occurs because it just occurs like other cancers, and probably is more multifactorial in etiology. But key takeaway is it's easy to screen for breast cancer. It's a mammogram. And as Sandra pointed out, we've got an amazing crew here that really goes out of their way to make that whole mammogram and breast screening process easy and simple and quick. You're in and out in no time. And then you just come back, a year later and have the study or the test again. I think I had mentioned that, there might be some individuals who are at higher risk for breast cancer. Those individuals, opportunities that they have to help reduce the risk would be, usually they're plugged in with a breast center or a cancer center, not because they have cancer or, breast cancer, but because that's where resources are available to help assure that they get the extra screening and attention that they deserve. And that is a standard of care. So high risk for breast cancer usually involves 2 breast exams a year, breast imaging, mammogram, ultrasound, plus or minus an MRI typically. Oftentimes there is a conversation with a medical oncologist. There's no known breast cancer, but one tool that medical oncologists have is a chemoprophylaxis. It's a long name and it sounds horrible. It has the word chemo in it, but it's actually a great thing. Chemo just means medication. So our medical oncologists have medications that are great at helping reduce the risk of breast cancer. It could be a medication like a tamoxifen or one of its cousins, class called aromatase inhibitors that are really great. We also are hugely lucky to have, one of Sandra's other hats that she wears is our nutritionist, dietitian guru. Do you run the nutrition department as well, Sandra?
The outpatient
Yeah,
nutrition
yes, of
services.
course you do. Yeah. So her services and her department services are available to our patients. Our patients really appreciate it. Sometimes it's just good in general to have a nutrition consult. It gives you an idea, in this day and age, it can be, we get all this input or no input as far as like what's good to eat, what's a relatively healthy diet, what kinds of foods can we eat that decrease our inflammation or just help us thrive, function better. Our bodies are happier and healthier. Is this a good time for me to ask you about some nutrition advice or do you want to do that later?
No, that's fine. So, there are different risk factors, right, for breast cancer or all cancers, if we want to talk about that. And I think that you are bringing up a very important point, which are the screenings. We need to get a screen to know if we are at risk. And that's very good part of it. But then also doing, regular self-exams, eating healthy and staying at a healthy weight. And this is because the obesity causes higher risk for breast cancer, and not just breast cancer, but other cancers as well. So if you start eating healthier, hopefully you start losing weight. And with that, you help to decrease your chance for breast cancer. Now, we can say eating healthy, but what is eating healthy? So eating healthy, and lately the way that we say it is to follow a plant-based diet. And it's funny, today I was driving to work and thinking, well, today is Halloween. Where do candy come from? Sugar. And sugar comes from sugarcane. That's a plant. So I can have a plant-based diet and only eat candy, right? That's what I was thinking this morning. And no, the answer is no. Because yes, plant-based diet, but plant-based diet means whole foods, not super refined foods. Sugar will be a super refined food. So that means eating more whole grains like beans, lentils, and chickpeas, brown rice, for example, instead of the white rice, or whole wheat bread instead of bread. And trying to eat lots of fruits and vegetables. And lately there has been a lot of research, a lot of around berries, like blueberries, raspberries. All of those seem to have a lot of antioxidants that actually help to prevent cancer or kill those cancer cells, right? So there is no decisive evidence of that, but definitely, countries where people eat these foods more or more of a plant-based diet, Mediterranean diet, they have lower risk and lower prevalence of cancer and also cardiovascular diseases. So when you eat a lot of fruits and vegetables throughout your day, salads and vegetables that are not white vegetables, the way that I like to say it's like not so much like potatoes and rice, even though they're vegetables, right? Somehow. It's more of those rich nutrient foods. So grains is obviously some of them, but then we need to start incorporating more different foods into our diets, like couscous and miso and many other different grains that we're not used to eat on a regular basis, but that are actually very good for us. Salads should be a staple with every meal, and choosing vegetables that are very colorful. That means carrots, that means broccoli and spinach, and not so much of like that light green lettuce that doesn't give us a lot of nutrients. And then when it comes to fruits, same thing, like all fruits have a benefit. And the darker the color, I like to say that the darker the color, the more nutrients it gives us. So for example, if you were going to choose into like those like black grapes and green grapes, guess what? Like the black grapes will give you more nutrients than the green grapes, so always try to choose things like foods with the deeper colors because they have more nutrients. Another recommendation to prevent cancer, and even for people who have cancer, is omegas, omega-3 fatty acids. And the reason for that is because they are anti-inflammatory. Where do you find them? You find them in fish, like salmon, for example, or you can find them in avocados. Definitely dressing your salads with olive oil. Don't use olive oil to cook. You kill the benefit of olive oil when you warm it up. So olive oil should only be eaten raw. You could cook with canola oil. It's going to give you a lot of those antioxidants as well. But we should be eating fish at least 3 times per week. And it doesn't have to be expensive fish, because a lot of people, you know, when I say fish, they raise their eyebrows and they are like, oh, well, that can be expensive, but it could be tuna from a can. And if you do a tuna sandwich, you know, that's healthier than eating a full steak, and it's a lot cheaper. If you think about it, you know, a little bit of tuna and lemon and garlic, that's it. You know, 2 pieces of bread, good to go. And also, calcium is very important, especially for women. We lose a lot of calcium, so it's important that we keep those reserves of calcium. And for that, you know, eating dairy, or if you are lactose intolerant, and there are some other foods, right? Like tofu, for example, that you can eat, or some other substitutes like almond milk or pea milk. So it's good for you to eat that. But also vitamin D. There has been some studies that actually show the relationship between vitamin D and cancer and obesity as well. So it's good to take a little bit of sun, not too much. And if you do, you know, it's only for 15 minutes a day. And if you put a lot of sunscreen, you know, that's not good either, because then you're defeating the purpose. But no more than 15 minutes. The idea is not to get a whole tan or anything like that, because then we can get a skin cancer. So another type of cancer, but just a little bit, just to help your body produce that vitamin D. And especially if you don't drink a lot of milk, or you don't eat a lot of dairy, which is the main, which are the main sources of vitamin D, then you definitely need a little bit of sun. But vitamin D, you can also get, you know, from different multivitamins, or you can get, you know, different foods that are fortified with vitamin D. That means that vitamin D has been added to those foods, like orange juice, for example. Some of the orange juice comes with calcium and vitamin D. So that's a good thing to incorporate into your diet. But then again, it's a processed food. So you need to watch how much of that orange juice you're drinking. But if you know, make your own orange juice, that'll be good. But then that orange juice doesn't have calcium and vitamin D. So in a nutshell, because I could talk about diet forever and ever, but in a nutshell, please start eating more plant-based foods, cook more. Processed foods are not your best friend. They are, because they save you time and you don't have to clean your kitchen, but your health pays the consequences. So, you know, cooking a little bit more, eating more plant-based foods, plenty of fruits and vegetables, making salads a staple, dressing your salads with olive oil, fish 3 times a week, and then plenty of berries. Those are all good habits to have if you want to prevent any type of cancer, actually. So thank you for that question.
That's excellent. Thank you. And as you point out, it's not necessarily so expensive, and sometimes you know, a healthy way to eat can be less expensive, like lentils and rice is pretty inexpensive, you know, for a bag. It could be like pennies on the pound. The downside, as you point out, is you do have to cook it, you know, it entails some time cooking, but the health benefits, you know, are tremendous.
Yeah, and sometimes, you know, it's also cheaper to get the canned foods. And I know that we always have to make this disclaimer, or at least I always do it when I talk about canned foods, right? Because it's like can come with a lot of sodium or salt, which is not good for us either. But if you rinse anything that comes in a can very well, then you're taking out all of that salt. So you can definitely buy canned beans, for example. I love canned chickpeas, and I just rinse them well, and I add them to salads, I add them to my rice, I add them to pretty much anything because I love chickpeas. So, and you can do the same, and it's not expensive. That's what I mean. It's like everybody thinks that eating healthy has to be expensive. No, it doesn't. There are a lot of options out there.
When you do nutrition consults and you meet with people, do you guys give people ideas as to, where to get recipes or, what types of meals to put together, stuff like that?
Absolutely, all the time. That's what we do.
Yeah.
So, I think in the older times, and not so old, to be honest with you used to go to a dietitian, and the dietitian used to be like, okay, what's your weight, what's your height, and let me see in my drawer, and this is the diet that fits you, right? And we'll give you a diet plan. Those days are over, thank God. Now when you go to a dietitian, we talk to you, we ask you what you like to eat, how much time do you have for your meals? Do you cook? Do you have cooking skills, or do we have to start from scratch? And it's more like a skill builder. We teach you from how to shop for the healthier foods that you like, to how to make modifications to meal planning, to cooking, all of that, to start changing your habits little by little until you eat a healthy diet, basically. But it's a whole process. So no more of those 1,800 calorie diets that were the same for everybody now. Now, everybody's different. The same way that you were talking about having different treatments for each person, and that is not the same, that now everybody gets the same treatment for breast cancer. Now it's the same with nutrition, right? So it's very individualized. So my dietitians do that, yes.
That's very cool. Thank you. Thank you for doing that. It's so appreciated. So breast cancer in general, incredibly treatable. It affects 1 in 8 to 1 in 12 women. It can affect some men as well. The percentage is just much smaller. But based off of statistics and how many people are affected by breast cancer, we probably all know multiple people or family members that have or have had breast cancer. So it's pretty common, and it's pretty non-discriminatory, meaning, anyone can get it, which means that we just really encourage people to do things to try to decrease the chances, and then do breast screening, which is a mammogram every year. And don't worry if you've missed a mammogram for a year or a couple of years, just get back on track. Everyone's been in those shoes. So, it's never too late. If you realize, oh, it's been a couple of years, or it's been 5 years, or it's been 10 years, no reason to feel any embarrassment or shame or anything. Just pick up the phone, make the appointment. And you'll be happily seen, you'll get your mammogram, and then move on with everything. Breast cancer itself, incredibly treatable. Treatments for breast cancer, very much specialized from one individual to the next, all based off of evidence-based medicine, protocols, strategies that have been proven to be effective. So the breast cancer treatment that would be recommended, should an individual have breast cancer, has been highly vetted, or a lot of research has gone into demonstrate that those are the best recommendations for that specific breast cancer treatment. So that's really lovely to live in an era where we are able to function off of really strong evidence based medicine. And that's really lovely.
Dr. Mitchell, I have a few questions,
Yeah.
if you don't mind. Are there any signs or symptoms that we should be aware of and kind of get our antennas on them?
That's a really good question. So, typically we might say, if you notice a bump or a lump in your breast, or when you're doing your regular breast exam, an area just feels a little different, like a little nodule, or maybe the skin feels a little bit thicker or different, or there's some redness in your breast. Maybe you have some discharge or liquid from your nipple, or maybe you have a lump under your armpit, or in by your collarbone. These are things that you want to bring bring to the attention of your doctor. And it may not necessarily mean that you have breast cancer, but these are things that might make us want to make sure that you don't, or if you do, diagnose it right away so we can go ahead and get started with treatment. Ideally, most breast cancer is identified on your regular yearly mammogram, before you can even feel it or see it. But that being said, sometimes breast cancer occurs and it grows and it's this big lump, and don't hesitate, just call and come in. That's why we're all here. This is what we all do all the time, and yeah.
So
Sometimes
let's
also like a weight gain or a weight loss, or pain in maybe your bones or throughout your body. These are kind of non-specific, but make us think that maybe something is going on, and it's worth a trip to your doctor to figure out what's what.
Now, the risk of breast cancer increases as you age. And I believe, after 50, then it gets even more, right? Like the risk is higher. And you were just saying about those lumps and the pain in your bones. And I feel that a lot of women tend to think, it's menopause, I'm aging, everything hurts. So is it good to still go to the doctor, or is how to differentiate between, yes, it's because I'm aging, as opposed to I might be getting sick and my body's trying to tell me something?
Yeah, that's an excellent question. We probably don't talk about menopause enough. It's a very normal, natural time period in a woman's life, and it affects people differently. Those are excellent questions. So anytime there's a change, in how you feel or in your body, if you're not confident that that's a normal process, it's always a good idea to, give your primary a call, or if you go to the breast center, give your breast surgeon a call, and get it checked out. The most common age for breast cancer is around 65 to 75. That being said, women can get breast cancer, much younger, which is why we typically start breast screening at 40. And even younger for people who we know may have an increased risk for getting a breast cancer even at an earlier stage. But you bring up an excellent point. The time period of menopause can run the gamut in different feelings or sensations, or changes in your body. So a good relationship with your primary care and or your gynecologist, where you go in every year for that physical, and they will let you know what to expect, what would be a little bit different or a little unexpected, and help manage. It's an excellent point.
Now, Dr. Mitchell, tell me if I'm wrong, but I feel that, yes, we usually wait, a whole year to go to the doctor. But if I start feeling something, I don't need to wait a whole year, right? I should go to the doctor right away and ask for like a sick visit or something, as opposed to my physical.
Absolutely. I mean, life happens in between your mammogram appointment every year, or in between your primary care visit every year. So, yeah, you know what? Uh, address everything as it comes up. And, our primary care and our gynecologists, they're so efficient these days at being able to respond to questions. Sometimes they'll have you come in. Sometimes they can answer questions, remotely. But absolutely, life happens in between your mammogram appointments, in between your gynecology appointments, in between your primary care appointments. So there's no reason to wait. Call and make an earlier appointment, and get it checked out.
Mhm. What's the youngest that you recommend to get a mammogram if, for example, you have a strong family history,
So
other breast
yeah,
cancers?
so that's a very interesting question. So when people are at known higher risk, or they have um, family history of breast cancer, we typically recommend breast cancer screening 10 years before the youngest person in the family ever had breast cancer. Usually mammograms are started around age 35 or 30. Typically, we don't do mammograms in the 20s. That being said, there are exceptions to that. So, we know that some groups of people from around the world may have a typical earlier onset of breast cancer. So breast cancer at a younger age, like 30s, 40s, might be more common than it is amongst Caucasian women. So it's a study in progress to figure out exactly, the current recommendations of breast cancer screening starting at age 40 with a mammogram. There is some evidence over the years that shows that some people from a variety of parts around the world may actually benefit from earlier breast cancer screening. So that will have to be figured out, like everything in medicine.
And what about genetic testing? Is there an age for genetic testing, and who's eligible for genetic testing?
Yeah, so what most geneticists will say, it depends on what it is that they're looking for. But regarding if someone wants to see if they have an increased risk for breast or ovarian cancer, perhaps if they're BRCA positive or some of these other genes that are associated with breast and or ovarian cancer, when the individual is old enough or mature enough to deal with what the results are, whether they be positive or negative. So the geneticist will sometimes meet with an individual, and if that person says, regardless of their age, if they're in their 20s or their 30s or their 40s, that individual still says, you know what, I don't want to do it, that is no problem whatsoever. And sometimes that I don't want to do it is age related, and sometimes it's just personal preference related. So the younger women that we see that are pretty gung-ho about getting genetic testing are probably in their 20s.
Hmm, okay. And we have a question here. Why is the risk higher for women age 50 and over?
I think it probably just has to do with age. Like many types of cancers, some types of cancers have what's called a bimodal distribution, where there might be a common young age that is affected, and then also a common older age. We know that when human beings live long enough, about 85% of human beings will get some kind of cancer or another. It's what the body is susceptible to. And we know, just based off of, observational studies, and staying aware of how old people are when they're diagnosed with breast cancer, that the most common time period is around 65 or 75. And that's probably multifactorial and or age related.
Okay. Um, I think I'm done with my questions, actually. But we're also having a little bit more time. So I don't know if we have any more questions from our participants, because remember, it's not every day that we have Dr. Mitchell here to answer all of our questions. This is really a luxury. So please hurry up with your questions before she leaves. Biopsies. I know that sometimes, people need to get some biopsy, but you didn't mention any of that. You mentioned the mammo, the sono, the MRI. So biopsies are not needed anymore.
Hopefully someday they won't be, but yes, they are a very, very important part. So when you go in and get a mammogram or ultrasound, a sonogram or an MRI, the radiologist will read that study and they'll give you a score. They'll say, come back in a year, or come back in 6 months, or I really recommend a biopsy of this area. So the biopsy of that area could be done under ultrasound guidance, or it could be done under mammogram guidance, which is called a stereotactic core needle biopsy. It could also be done under MRI guidance. So it just depends on how the area that should get biopsied, where does it show up the best, under which type of mammogram, ultrasound, or MRI. Most of the time when those biopsies are done, the result will actually not be cancer. So that helps us feel, when you're the one getting the biopsy, it should give you a little bit of comfort. It's kind of stress provoking anyway. But the radiologists are really great at getting those biopsies done in a timely manner, and our pathology department is superb. They do an excellent job reviewing that tissue and getting results for us. So the biopsies are, on the breast are very doable, and the results are back. And then we get to know, what's what. So yeah, that it's much over the years, it's evolved into a smaller and smaller procedure. So yeah, you can totally get through it.
And one last question, and then we will let you go, but just to end on a positive note, what's the survival rate? And I hope this is a positive note. What's the survival rate for breast cancer?
It's incredibly high. It's in the upper 90s. It depends on the exact stage that we're talking about, but most breast cancer, the survival rate is in the upper 90%. We can break it down by stage, but breast cancer in this era, especially meaning today, if you were diagnosed today, or especially early stage breast cancer, so earlier breast cancer, is incredibly treatable. And the majority of people in that situation will get their breast cancer treated and then move on with the rest of their life. The nice thing is the treatments have become so tailored and involve less side effects that they used to, that the ideal is that a woman gets her breast cancer treated. And, part of that is maybe surgery, radiation, medication. And then when she's done with treatment, continues to move on with her life, enjoy life, and, get routine imaging if that's appropriate. But eventually, maybe it's not even at the top of her mind anymore because it's been taken care of. So we see that more and more. We did not used to see that, but that is a direct result of the treatability of breast cancer.
Yeah, that's definitely great news. And we have a comment here, Dr. Mitchell.
Yeah.
It says, this is informative and frightening. I hosted a breast cancer awareness last Wednesday. My colleague shared that her siblings were diagnosed. So as the youngest sibling with dense breast, she had a sonogram, a mammogram, an MRI, and a AI exam. Can you elaborate?
Well, I don't know the specifics of what that individual had. If the question is something about an AI exam, we do know that there is software. So there's a complement to the ability to read mammograms that incorporates AI. And there have been a few studies, I think in Sweden, perhaps, within the past year or so that have demonstrated that when AI is added to a mammogram read, a radiologist, that the sensitivity and the specific, it might be better or stronger. So that's in the process of getting better and better and development essentially, but it's not a bad thing. It's a good thing. It just provides more information, and we're really happy to benefit from any advances in technology that afford all of us the ability to help, detect breast cancer earlier, treat it better, more efficiently, so that individuals who are getting that diagnosis and that treatment are able to move through the process easier.
Yeah, well, thank you so much, Dr. Mitchell, and all of you who came to join us today and for your questions and comments. And that's it for today. Don't forget, if you haven't had a mammogram, or if it's time, please schedule it now. Do you by any chance know the number to call? No, right?
I
was just looking for it. But anyway, you can always call 845-348-2000, and you can ask to connect with breast center, and that way you will be able to schedule your appointment. So again, it's 845-348-2000. You want to come here at the breast center in Montefiore Nyack. And again, please do so. Prevention is key. You heard the treatments are really good. The mammograms are not as scary. They're not pleasant, I have to say, but they're not as scary anymore. And please join us next week. I can't believe it's November. November is diabetes month. That's our specialty. So next week, we're going to have diabetes uncensored. We're going to be talking about why it's so difficult for people to manage diabetes from the point of view of those diabetes educators that hear it from patients themselves every single day. So please join us for that. And again, thank you so much, Dr. Mitchell. It's always so nice to see you and talking to you. And thank you for educating our community.
Thank you so much. Thank you. Bye-bye. Thanks.
Bye-bye.